Hello and welcome to day 2 of the ERS Summit on Digital Respiratory Medicine, Realism versus Futurism. For those of you who were with us yesterday, you will know that we covered a vast amount of ground on the virtual world, on wearables and apps, contact tracing, and the management of digital exclusion. We have much to pack in today, this morning, and we will be covering a range of topics, important topics on AI, the ethics of AI, involving humans in the loop. We'll discuss EU for health, the EU data space and appropriate levels of regulation and governance. And then we'll deal with big data and its uses, and that is on surveillance for respiratory diseases. We'll also hear about the use of big data for pharmacovigilance, and then the use of it in decision-making, machine learning, and how it can help us in our everyday practice. So with that, I will hand over to my colleague, Tamsin Rose, to kick us off for the day. Tamsin.
Good morning. Ethics, equity and regulation. That's our topic for this morning. And just to remind you, we have an open poll and we were asking you, what are the key points that we need to consider in digital health? And the votes are still coming in, but up at their equal first place at the moment is regulation and data safety. So this theme is very important to our audience. And I'm delighted to introduce our first speaker who's going to help us explore particularly these areas of regulation and data safety because they fall within his remit. So we have Pierre Del Sante from the European Commission, from the DG Santé, the Deputy Director General, and you're going to help us understand the big ambitious plans that we have at the moment for data at European level. Because the beginning of this mandate for the European Commission and the European Parliament, digitization is the red thread that runs through it as being the key to opening up our economies to be fit for purpose in a post-industrial age. Then COVID hit, and we yet again learned the importance of data for both our response to the pandemic and planning for what's to come. So Pierre, perhaps you'd like to start by giving us some insight into the plans for the Health Union and how the health data space will be a key foundation stone to achieving a healthy European Union. Pierre.
Thank you very much, and thank you very much for your introduction, Tamsin. And also good morning to everybody. Of course, it's a pleasure to be here and to discuss such an important topic. You know, coming back to your point, you mentioned the fact that the Commission was insisting on the need of having more digital in our world, in our economy, but that's true also for the health systems. If you look at, what happened during the COVID crisis, as you mentioned it, we were forced also to use much more digital to just, even for simple things like tracking apps, and now everybody's waiting for the digital COVID certificate, which will be an electronic tool. And so it's clear digital will be extremely important. And actually today we are having a digital meeting, and that's becoming now the norm. So that's something which is clear. So one priority for us is we want to make sure also that the health systems move also to the digital dimension, because that's something which is extremely important, and we need to make sure that it's something which is will be developed also at the EU level. Fundamentally, we are working now on the legislative proposals which will be focusing, and we call it European Health Data Space, which will be focusing on establishing a framework, a legislative framework, but also a practical, technical framework for how we can improve the situation in Europe with respect to digitalization of the health sector. As you may know, probably the Commission has adopted a general legislation on, digitalization, and we will be part, will be a specific legislation built on this general legislation. Now, what do we want to achieve? Basically, and if I want to simplify, what our intention, and I'm not going to into the details now, but basically we have two dimensions. First of all, we believe it's important that patients have a better access from a digital point of view to their data. We believe this is something which is extremely important. And that's also important because we live in a European Union where people are moving from one country to another country, even only for holidays or because they work abroad. So it's important that we also create this kind of free integrated market for data for patients. That's one dimension which is extremely important. And the second dimension, which also for us is fundamental, is that we want also to have those data to be exchanged for researchers. Because we know that one key aspect to improve the research in Europe and to have innovation in Europe is access to data. And so it's fundamental, actually, that we create this huge amount of data at European level to make sure that, researchers, hospitals, everybody who is able to get access to those data will be able to use it and to develop new techniques, new medications, new drugs, new vaccines, potentially. And of course, in this context also, the use of artificial intelligence to monitor, to try to research those data will be extremely important. But I have one very important element also on which I would like to insist. Because we are talking about medical data, it's clear that the data protection is fundamental for us. We want to make sure that we fully comply with the rules of the data protection regulation, because that's clear. We cannot deviate from this, especially in the health sector. But again, the message I want to convey is simply we have the capabilities in Europe. We are already seeing that a lot of things are taking place in the health sector with respect to digital. Telemedicine is growing also. That's another dimension which is important. So what we really want to do as a Commission is to put into place the legislative framework, which would, on one side, favor more cooperation and more exchange of data, but on the other hand, we'll make sure also that our citizens are protected and their data are protected. So that's this combination that we want to put into place. And also one other dimension on which I would like to insist, having a regulation is one important aspect. Of course, clearly we need to have it, but we need also maybe to help, the technical dimension by maybe financing some actions. And as you may know, not everybody probably knows it, but anyway, as you may know, we have now a very ambitious program, which is called EU for Health program at the EU level, which quite a large amount of money, which would help us to finance action. And of course, in this context, because, digitalization is so important for us, it's clear that some of the actions that we intend to finance with this amount of money will be focusing on that aspect of how to make the health sector more digital. And for us, that's something which is extremely important. So it's regulation on one side, making sure we have this, common framework at European level. It's making sure we protect data protection is essential, but also that we put the money to make sure that we develop some concrete actions which will make a difference.
Thank you, Pierre. Something that came up yesterday, I think, was quite interesting, is the importance of interconnection, not just interoperability, but the connection between different data sets, and that needs to be used. At the European Commission level, of course, you have the European Commission, you have technical agencies like the European Medicines Agency, the European Centre for Disease Control, even things like the European Environment Agency, which has important geospatial data, which helps us understand, for example, air quality. How do we make sure that all of these different elements work together and that they are able to access and contribute to a very holistic and complete data set?
First of all, you have to distinguish, we have two issues here. First of all, we have to make sure that we have connection between, like you mentioned, the different agencies and the European Commission, which is already taking place. So we have a project which is being developed now, where basically we are making sure that there is really a connection between the European agencies and the European Commission. But what we want to do is broader, actually. What we really want at one point is just basically that a researcher, somewhere in Lithuania will be able to get access to data of an hospital in Greece. And of course, in a way which is secure, protecting the privacy of the people, that's very clear. But basically would be able to use those data and just to be able to develop maybe new research and to develop new drugs. One thing which was also striking, and it's a slightly different issue, but it's still very interesting. When you look at the way, we are now talking, of course, COVID. We have the new vaccines against the COVID, which are very important. But they were tested, those vaccines, clinical trials. And actually, most of them were tested outside of the EU, simply because there was not a system of the EU which would allow clinical trials at European level, but also exchanging data in a way which is efficient. What we are changing this. What we really want now is that in the future, you will have a huge amount of data which are there, gathered at the national level, at local level, which will be put in a big pot of data, if I may say, express myself like this, and which will be accessible to everybody and to make use of it. Data are really, it's obvious, but data are the gold of the future, That's something which is fundamental, and by, putting those data together, giving also the tools to researchers to dig into those data and to find new elements, we will make a difference. And that's what we want to do. We want actually Europe to remain at the lead, in terms of research and innovation in the health sector, and we believe one key aspect of this is really the digital dimension. Again, we are not the only one to do it, Other parts of the world are doing it also. But because of the fact that we are 27 member states and so on, it's a bit more complicated in Europe. But what I would say is that there is a wide support, so far at least, there is a wide support from, member states, from stakeholders to go into that direction.
Thank you. Let me remind our audience that they have the opportunity to submit questions or comments using the Q&A function that you'll find at the bottom of the screen. And after each of our panelists have had a chance to speak, I'll be bringing in questions from the audience. So do use the function. Let me ask you now a question, Pierre. You've described that we've got gaps and that we couldn't even hold some of the clinical trials for the COVID vaccines in Europe because of this fragmentation. What do you see as being the main barrier, and how do we overcome that?
First of all, I'm paid to be optimistic, and I see that things are changing. So as I say, things are going in the right direction. Again, I give you very, maybe relatively limited example from a technical point of view, but which are extremely important. The COVID tracking application, which, was a success because it has been basically adopted by all member states and there was interoperability. We are now talking about the digital COVID certificate, which will enter into force very, very soon and which will make a difference. But again, other products, other things are also moving. We have an application which goes My Health for EU, which already allows a certain number of data to be carried by the patient when he goes abroad. And several member states are doing it. So to come back to your question, I believe we have two aspects. First of all is the question, obstacles, I would say. First obstacle is clearly the question of data protection. There is always a fear that the data will be used for reasons which are not very good. And that's a normal fear. So I'm not, discarding this fear. And we need to put into place a safeguard to make sure that data will be used in a safe manner. And we can do it. It's possible to do it. And we will do it. So, but it's clear, it's a fear which, to a certain extent, it's an obstacle, let's be clear. Second obstacle, of course, is clear that when we talk about health sector in Europe, you still have a lot of diversity between different parts of Europe. Not everybody has the same level of equipment, of course, everywhere in Europe. Even between regions, you have different, in the same country, you might have differences between regions in the same country. So that's another problem, of course, that's on the ground. You still have a lot of differences between countries, or as I say, even regions within the country. So that's the second element, which is difficult. And then simply it's maybe also the fact that, the health sector has been relatively traditional in the way it has been working so far, and that's not a criticism. That's very good. And so it needs always, a little bit of time to change to a new situation. But again, one probably aspect, I wouldn't bear positive because I don't believe there's any positive aspect from the COVID crisis, but at least one aspect of the COVID crisis is the fact that people are getting used now to use more digital environment. As I say, we are now having this kind of meetings through a digital environment. So it's becoming much more part of the new normal. And when you look at people wanting to do teleworking, so it's becoming part of the new normal. So I would be, from that point of view, it would be also a very important push, for also in the health sector to develop more digital solutions. And again, if we want to remain innovative, we need to use those data. We need to use artificial intelligence. We need to use those data to make sure that we develop something which will help to protect our citizens in the future.
Thank you, Pierre. And a final element I'd like to pick up on, which is moving beyond health. Obviously, the sheer amount of data that's going to be generated. We've talked yesterday about wearables. Not just apps, but wearables generating information all the time. Obviously, this is, if you look at the digitization of health, it isn't just about the apps and the system, and the technology and the software. It's computing power, it's computer chips, it's server farms. Maybe you could give us a little bit of insight about how across the Commission, including areas around competitiveness, connectivity, industrial strategy, how you're seeing the needs of a digital health sector being integrated into these other big infrastructure projects, looking at moving the EU into the digital area.
As you know, the EU is investing quite heavily, for instance, in high power computing, in very efficient new type of computers. We are also looking at quantum technology, which, because quantum computer will be the future. And, we are also investing massively in this kind of, new development, which will, of course, take a certain number of years before we are there. So it's clear, as you said, more data needs more power to analyze those data. And more development and more tools, artificial intelligence and so on, to be developed to do that. But again, as the Commission is, maybe we might have different services within the Commission, but we are still one big body. And we work together. So it's clear that we are in constant contact, for instance, with our colleagues from DG Connect, which are also massively investing in developing new form of computing and new form of more sophisticated way to use data and so on. So we are in close contact with them, and clearly health should be part of this because again, because of the COVID crisis, health is becoming a priority, has become a priority for everybody. So we cannot ignore health. So if we do something to improve, the use of digital in different sectors, health should be one of the priority. And one last element also, maybe because I don't know who's listening to this conference, but clearly, as you know, member states have now to submit their plans for the recovery and resilience funds, which is a huge amount of money which is available there. And clearly, we have, as a Commission, we have identified two priorities, but three, green being one, of course, but digital and health. So, if member state, and I know it's the case, some member state could also come up with some project uses this money, to combine actually the two objectives, which is digital and health, and to come up with projects, ambitious projects, which will make a difference. And certainly we are willing to support this.
Thank you, Pierre. And this sounds like a great vision for the EU, but as you mentioned, the EU is a global player. Is this going to create a wonderful walled garden of protected EU data which we can use for generation, or how are we going to open this up to other parts of the world? Just as we benefited from vaccines where it was tested elsewhere, how would the health data space support global efforts for more integrated digital health?
The point is, of course, we are. I don't believe in fortress Europe, and especially when we talk about health, it's a global world. It's so we cannot live in isolation, and we don't want to live in isolation. So it's clear that if we build a system, we need to make sure that the system which is built is not necessarily closed one. But of course, there is one very important dimension. That it's clear, as I told you, data protection is fundamental for us. As you know, we have very strict and very efficient data protection rules in the EU. So clearly, we are not going to open, a system to someone who is not complying with our data protection rules. So I'm not making a commitment now, but I'm just telling you that because of the issue of data protection, we need to make sure that whatever we do on the international front needs to be consistent with this aspect. But again, sorry to be, we are not yet there. First, we need to build the European system, and then we'll see what we do with the rest of the world. To a certain extent, it's important first that we create something in Europe for the 27 member states. We put it into place, and then we'll see under which condition we can maybe open it to the rest of the world and so on. But that will take still a little bit of time.
Thank you very much, Pierre. And I'm sure there'll be questions to you as we move through the panel and get to the Q&A session. I'm delighted now to introduce our next speaker. That's Nikita Lukinets. You are the founder of Open Ethics and also an organized structure called Pocket Confidential. Most importantly, you have expertise in the management of innovation. And there's, I think, no bigger challenge to innovation than the area of digital health, because it has to have this balance between patient safety and security, but there's the potential for enormous leaps forward and huge amounts of heterogeneous data that needs to be managed in an effective way. So lots of things to pick up on. Let me pass the floor to you, Nikita. You're going to tell us a little bit more about the ethics and challenges of moving to an AI world. Nikita.
Hi, thank you a lot for having me at the summit. It's a great pleasure to be here and to contribute with what I'm working on. Today, I would like to talk to you about a concept that is called human in the loop. Human in the loop is the idea that is coming from a control and design of a control systems, which originated many times ago in the engineering space, and which is increasingly now appearing in the field of artificial intelligence, because what we know is that we have risk associated with the automated data processing. And today I would like to talk about this and about the ethics in the field of artificial intelligence in general. So let me proceed with the slides. So starting with the definition, we tend to talk about AI as a system that is capable of making decisions that were primarily attributed only to human professionals. And this definition is changing very much, because if 20 years ago we were talking about the spam filters as about something that is an AI or machine learning, today we tend not to talk about the spam filter or something like that, or about the OCR, optical character recognition. We used to talk about this as an AI, but right now we're not considering or perceiving this of AI. So primarily we need to look at two areas, which is our ability to perceive the environment and our ability to act to succeed at the goal, which the designers of the system have, or which the users of the system have. And I want to make sure that everyone is on the same page here. AI ethics is not about this, and our problems in AI ethics are not tomorrow, they are today, and they're related to our failure, our systemic failure in very concrete areas, such as privacy, cybersecurity, bias of the systems, ability to make fair decisions, whatever the fairness definition is. And the end discussion is always about what is actually the threat. Is it the hand or is it the hammer? Can we, human designers and human engineers of the systems and those who deploy it, can we prevent the systems to make bad decisions? And to make these decisions better, we need to optimize on 4 key areas, which is perception, decision, action, and then evaluation of the quality of our decisions. If we look at the way how the modern AI systems are made, or specifically deep learning or machine learning systems, we need to understand that the quality depends very much, as Pierre said earlier, on the availability of data. And the availability of data is not only our ability to collect this data from the environment, but also it's an effort to label this data and label it with high quality. This leads to the next question of how can we actually improve this, and what are the risks? Well, we know the risks. We know the benefits. We can be fast. We can augment human decision making. We can have hyper-personalized decisions or medicines or treatments in the case of the healthcare. We can, however, on the risk side, we can have a lower stability against adversarial input. So this is a very big cybersecurity question that relates to artificial intelligence. We can have a very high false positive rates or low accuracy. And this is sometimes why we would talk about the need of having a human to to confirm the decision of the machine. We can have a lower interoperability of the decisions. And what is meant by this is this is a system interoperability level. When in the early days of the IT industry, there were many companies that were doing any sorts of software development and software design plus hardware development. It was a complete industry. However, when the industry is becoming more mature, we observe that the industry tend to specialize. And as the industry tend to specialize, we see bigger players outsourcing a smaller parts of work or some parts of work to other vendors. And when this is happening, our safety and security depends not so much on the surface level, but on the all supply chain of decision making. And this is where interoperability comes into space. And when this happened, and we look at the whole spectrum of the applications in the healthcare, starting from surgical robots to epidemic prediction and prevention, or wearables, or narrowing the number of candidates for clinical trials, we start asking ourselves the question: how can, to which extent we can relay to the data that is, or to the inferences that is coming from the machine. And so I brought a little bit of context right now. And now what I want to narrow on a specific element of the AI risk spectrum, that is loss of trust, and where this loss of trust is occurring and why is it occurring. It's occurring due to low accuracy or lack of transparency about how machines are performing on their decisions, and potential bias. I'm not going to talk about discrimination today because it needs additional definitions, and we can go out of available time. But what I want to talk about is about the human factors, and where introduction of the human factors can positively help us in having high quality of this hybrid human and machine systems that provide the output to the end users. So we can make machine learning models more accurate. We can make machine learning models to perform better in a certain extent. We can have humans doing more accurate decisions with the help of machines, and we can have humans doing these decisions more efficient without moving the lever of responsibility. And there are two main domains, and where we can put human in the loop. One part of this is putting human in the learning of the system, is enforcing the quality of the training data sets. And another part is control systems. Today, I will talk more about the control systems, which is more natural for a health expert or healthcare expert. We tend to think that there is only one way to have a human control, but there are actually many. And the typical way you would think about human control is the way it is presented in the GDPR Article 22, which says that if you are a subject of automated data processing in the critical environments such as financial field or legal or healthcare, you should have a right to come back to a human and reevaluate or evaluate or confirm your decisions. Now, when we think about actual design patterns that we can introduce, there are much wider. So first of all, isn't on the design sides, is who and how do we combine those systems, and we can have them in the different ways, such as a swarm control, where we have multiple robots or multiple AI systems, either of a similar design or a complementary design, working together. Part of this is implemented in so-called adversarial neural networks that are playing against each other to achieve better performance. We can have a human counsel, like a doctor counsel, which is a very, very usual practice in medicine when you are not sure about the diagnosis. We can have a crowdsourced approach where multiple users, both expert and non-expert users, are confirming the decision or evaluating the decision of the machine, as well as let's say the first thought scenario where there is a human expert. But this is only part of solution. What is important to look at is also how the systems are organized together and who is put first. Is it the human that is suggesting the decision to a machine evaluating the decision of the human and separately the available data and then making a final decision? Is it the human that confirmed the existing decisions? There is a whole spectrum of how those confirmation or evaluation human in the loop could be put in place. And where we need to look at is that there are 3 or even 4 critical areas, such as annotation errors. We need to work more on and be aware that the way the data is annotated, for example, is very much impacting quality. So if the human expert is working on different sequences of the data, and the sequence of the data that the human expert is validating is different, this can affect the quality, even though the complete data set is exactly the same. Another element that we need to be aware of is that we need to have an explainable or middleware solutions to those validators, so that the validator will also know how the machine is making the decision and whether the factors that were taken into account are important or not. So this can really help human validator. We need to be also aware that in the design of cyber physical systems, we may want to take a human reaction, so a native reaction of a human body, not only how the human is mentally labeling the data or mentally. We may have a way to measure whether a human is sure or confident about his decision or not. So to be aware of the degree of confidence. And also we need to have a redundancy for safety in the way we label the data. So to sum up, we do need to have a standard, and this is what we're working in open ethics. We're working on the open standard to talk about this sort of problems, to have a common language. And here you have just 2 print screens that talk about the self-disclosure of the system, meaning that the owner of the system can explain how the system is working and what sort of design is put in place, so that in the decision supply chain, we can understand what is the weakest chain of and which is the system that may lead to a potential problem. And what we're building finally is we're building an so-called an open ethics transparency protocol. It's a protocol for one machine to exchange their ethical posture and the way it is constructed with the other machine. And eventually what we're going to, that every machine, like the passports of electrical appliance products, we need every machine to have its own passport that will talk about the specifications in a very transparent and a standardized way. And this is just an example of such a protocol. And the very last thing that I want to say in my today's presentation is that, well, human in the loop is an important element, but what it does, it shifts the responsibility. It allows reassurance and two-way communication, but there is no 100% guarantee that it's going to improve the quality of the decision. For example, there is a research that I'm not presenting today that is saying that there is a risk of over-trusting the machines, and where human validator without the sufficient degree of responsibility will confirm everything that the machine is giving to him or her. So that's another risk that we need to mention. And to finalize, I want to invite everyone, if you do have questions, is to contact me at openethics.ai. And if you're a volunteer, this is a completely open source initiative. So you can contribute both by promoting this standards, or by writing a code, or if you want to be an ambassador of this standardization effort, please feel free to join the initiative.
Great. Thank you very much, Nikita. It was very interesting to follow and to try and understand, the complexity of the decision-making process, and you identified for us where there is an importance that humans play a role and take a responsibility. And also, I liked the way you described the evolution of technology, how in the beginning you had one player that did the whole process, the hardware, then the software and the product, and now we have these global supply chains with pieces of it outsourced, and that there are weaknesses in each of those chains. So I think that's really useful. Thank you. Reminder to the audience, if you have questions to our panelists and to Nikita about, the ethics issues and where the gaps are, please put them in the Q&A function and we'll pose them to him after our next speaker. The next person who's going to talk to us is Dennis Falzon, who's from the World Health Organization in their global TB program in Geneva, and previously worked in the TB program in France. Now, TB is both one of our oldest enemies in humanity. We found the TB bacillus in the pharaoh of Tutankhamun in his mummy. So it's been around with us for a long time, but we seem to be losing the battle. We have multiple drug-resistant TB, extremely drug-resistant TB. We are in a sort of long-term arms battle with TB. So I'm interested in hearing what you have to tell us where digital has a role to play to sharpen our weapons to tackle this very old foe of humanity. So Dennis, the floor is yours.
Thank you very much, Tamsin, and thanks for the invitation to WHO to join this very interesting set of discussions that you are having today. So I can maybe pass to my slides. So that's my declaration of interest. So we have in the past received funds from the European Respiratory Society to work on digital technologies and lung health, and we have no other conflicts to declare. This is just a snapshot to continue on what Tamsin is saying about the importance of TB in the world today across all the countries. So we estimate that a quarter of the world's population is infected with the bacillus and have a possibility that they develop disease during their lifetime, and about 10 million TB cases evolve every year, of whom about 1.4 million die every year. The numbers for 2020 will need to be reassessed in the light of the COVID pandemic and the disruptions that has caused. And again, usually we have about 500,000 cases with multi-drug or rifampicin-resistant tuberculosis, which pose a specific problem. But coming to the Ehealth, so we have been working for a number of years now systematically on different aspects of digital technologies as they can support the TB programs. And these are some of the basic definitions. I'm not going to go through them, but I think the important one, digital health at the bottom, is the one that is all-encompassing and the overarching term that we use to refer to what previously we used to call Ehealth and mHealth, but which now increasingly captures many different dimensions that were previously not included in digital or Ehealth. This is probably one of the earliest documented articles that I could find where attempts were made to digitize data for TB. This is from the early 70s in Southern Africa. And you can see that already there were attempts to computerize the processes to collect information in a digital format. So maybe even from this very rudimentary example of digital technologies, which has not been achieved in many countries, one has to say, even this level of registration, but we can go into more complex interactions and complex processes that are presented today. And when we started this process about 6 years ago, in collaboration with the ERS, in fact, here at WHO, we set out this conceptual framework to position different electronic products and digital products into these 4 buckets, with the understanding, of course, that there is a load of overlap between all of these different areas. So, for instance, this burgeoning area of digital adherence, medication adherence technologies would come into patient care. Then there are other technologies which are used for program management, such as the one that I showed you just now that has a very long history. Then there is also the elements of surveillance, which are being powered more and more now with the possibilities of integrating GIS data, and then the whole space of e-learning. So maybe I can just also present some other conceptual frameworks that can be used. This is another document that WHO has presented. This is much larger than TB. Now this is a document that has been designed to show how the digital technologies can help at different steps of the whole pathway for healthcare within the context of universal healthcare. And you can see another way of looking at this via pathway, starting from birth throughout all the health processes that person can undergo during their lifetime. So I invite you to go into those documents, look at them, and also check on the concepts that are put in there. So just to go over some common premises when we digitize healthcare, I think one of the key principles is really about communication, right? And then this key assumption that any improving communication is critical to improving behavior and getting people to have healthier choices. And then that as a consequence, if you improve the data behind the communication, this can improve decision making, it can improve the performance of processes, lower costs. And that computerization facilitates this process and therefore increased global access to equipment, to software, connectivity, telephony. All of this can improve, as a result, healthcare. So there is, I think, a lot of the processes within digital health that are premised upon these assumptions. And of course, whenever we do an intervention, as in any other space, we want to make things better, right? To improve things or make them cheaper at the same level of effectiveness, or improve quality, which is probably an element of effectiveness as well. But or preferably we should be doing both, right? And trying to get both. And I think this is an important graph to keep in mind, because sometimes we put in place interventions with a particular intent, and then people have raised expectations on what they can do. If you put in a process which is intended to lower human resource in the processes, but it doesn't affect the effectiveness, then of course you achieved your goal, but some people might become disappointed. But it's very important to keep this in mind, because often I feel that there's a lot of expectations on these products. Of course, there are many other elements to outcomes that we want to make sure that that are in place, and many of these are relevant to digital health. We want to have certainty in the evidence. Very often, digital technologies are put in a context which differs according to however you put it in different countries, right? Even sometimes in different countries or in the same country over a period of time. Different populations, of course. We have to make sure about that any digital technologies that we put in place do not upset equity. There's evidence of this coming through with the COVID, and also issues about acceptability, feasibility, and so on. So, well, of course, certainty, as I have mentioned, is very often low or very low whenever we assess evidence related to digital technologies, and that's because very often randomized controlled trials, for instance, are not performed or very difficult to construct for certain forms of certain processes, while for others, like digital adherence technologies, for instance, you find RCTs that have been reported. But so very often there are lots of best practices that have been put in, data coming from qualitative studies. So the evidence base for digital technologies in TB remains low. And so the coronavirus, amongst the other things that it has done, it has again shown out the digital the inequities even more. We have been, as a WHO, we have been doing a number of surveys in the past. This is the latest one we did from the series of the Pulse surveys, and it shows about the number of countries that, or proportion of countries reporting use of telehealth technologies to overcome the barriers imposed by lockdowns, etc. And you can see that there is a much higher sort of frequency of reporting from countries that are richer than the low-income settings. And again, when asking about what are the barriers to telehealth, very often there are limited access to telehealth technologies, for instance, for patients and providers, limited organizational technical capacities to transition, etc. And then also security and privacy concerns, as you see at the very end. Again, I mean, COVID, I think, has, if you want to say, mention that it has shown some strengths in what is possible, and this is the possibility of rapid turnaround of data. And this map, which shows the vaccine coverage throughout the world in varying shades of green, is an example of this, because we have daily updates on this, on deaths, on number of COVID cases coming through regularly from most countries. And this has been a big asset and something that we are also using now for tuberculosis to get data at a much more frequent periodicity. Again, the use of digital adherence technologies for TB, they have been around. Many countries are using some elements, be it text, being video, be it electronic medication monitors, or other digital technologies to support patients, either in the private or in the public sector. So the notion is coming through. And again, with respect to e-learning, this is also something that has dramatically improved in the recent years. It has been there from the very earliest days, I would say, of computing. The idea of converting paper into digital processes is not new. However, the expansion in the availability of mobile electronic devices, in particular smartphones and tablet computers, as well as internet, more and more to different populations in the world, this makes it possible now to come up with these more and more tools to be able to improve learning. And it's something that also, it's a concept that can be scaled up quite fast, because very often once you develop products in one language, then they can be available in for much of the populations using that particular language. Very often it's language, it is a barrier, but it's once it's put in place, then it can be expanded. Of course, you always want elements of adaptation within the country and contextualization as is necessary. And just yesterday, actually, we released our WHO TB knowledge sharing platform. It's available also on the mobile platforms, and this gives access to our guidelines, our implementation aids, and eventually also training materials, which will come online soon on this. Another area of interest have been chatbots. Again, these are intended to be to replace some human interaction and questions, and they've been used very effectively in all spaces for services, of course, to get quick information when people are not available. And this is one chatbot that we have developed to provide information and answers via menu or via free text on an area of treatment of a form of drug-resistant tuberculosis. But these chatbots operate under machine learning and other areas of AI are coming in. These are just two examples here from the TB world. One is computer-aided detection to interpret chest X-rays for abnormalities suggestive of tuberculosis, coming with abnormality scores that can be then routed for further evaluation. And the images on the right are showing the use of gesture identification and recognition in order to ascertain a person's compliance with treatment. So just at the very end, I wanted to mention as well the importance of implementation research. This is a website that we have developed as well with our colleagues from Tropical Disease Research, which is essentially a toolkit to help people put implementation research in place when putting in innovations such as digital technologies for TB. Of course, it can be adapted for other innovations, but implementation research is really critical for digital technologies because very often their successful rollout depends on context-specific factors that need to be factored in. So essentially, in conclusion, I would say that new opportunities to improve TB prevention and care arise as digital innovations evolve. Digital innovations move much more quickly than the TB other technologies in TB move, such as prevention or drugs, unfortunately. So we always need to keep abreast and make sure that we are benefiting from and harnessing all the power that digital innovations unleash. And also we need to learn from one health condition and the other. I think tuberculosis presents as an important respiratory disease, right? It is a disease of major public health importance globally, and it cuts across also many other areas of healthcare. It's not just an infectious disease, but it is deeply rooted in social issues, in social and in lack of proper access to healthcare, etc. And again, the importance for the evidence of effectiveness that needs to be improved. We really need more data. We need to collect information whenever we innovate. I think that's a basic tenet, I think, behind all the work that we are doing. And finally, I'd like to thank many people who contributed to these arguments and slides, and not least the ERS again for its support over the last few years. Thank you.
Thank you very much, Dennis. So interesting to see examples, particularly around the world, the different readiness of different regions to use and implement, and also to understand some of the challenges. We've got a few questions, so I'd like to invite my panelists to respond to some of these questions in our discussion time. There are a couple here that are around the issues of ethics and human expertise. So I think that's probably going to be addressed to you, Nikita, but I'd also perhaps like Pierre, from the point of view of the regulator, to think how we address this. So we've got an issue here about the human expertise in the loop. How much of it is in there, and will that then limit our ability to develop AI and sort of release AI to deliver the best that it can do? And then who's going to monitor the quality and effectiveness? Nikita, would you like to start on that?
I have 2 points on that. Data is very capital-intensive process, specifically labeling the data. I'm not talking about collecting the data. Labeling the data today is managed either in-house. For that, you need to have an expert group who's going to label the data. You define the qualities and expertise and specifications, and you can control it. However, more and more we see the emergence of the third-party services for data labeling, such as Amazon Mechanical Turk. This is I'm not saying that this is a low quality, but this is a very cheap data labeling. And if we look at the startup world, the first narrative that you may see in the startup world is to launch the product as soon as possible and then see what happens and iterate and improve it. And we have a very high risks here because labeling data using such third-party services may negatively impact the quality of the data labeling. So if you don't have a ways to control the data in-house, or to have an external experts revalidating and validating this data, you may be in a big problem. One important issue here, that AI is bringing to us is a generation of synthetic data, which is primarily focused on solving privacy issues in the label data, where you don't want to have someone accessing the data and seeing it. So you would generate the data with the same statistical distribution that you're expecting, and you can generate as much as you want. But here again, you are balancing the problem of privacy with the problem of accuracy, or you're balancing a problem of fairness with a problem of accuracy. So both of them should be solved simultaneously, and sometimes it is not possible mathematically. So you need to either have a huge budget and solve them both, or you need to have different fairness constraints, or you need to have different requirements for the data labeling qualities. Sometimes crowdsourcing can help a lot. As you know, Wikipedia is a great example compared to Britannica. In 2009, the error compared to years 2000, the error rate in Britannica was 3 per 1,000 articles, if I remember, and in Wikipedia much higher. In 2009, the error rate in Wikipedia was 4 per 1,000 articles written by non-expert professionals. So we see that the crowdsourcing can be a treatment sometimes. That's what I have to say.
Okay. Nikita, could I just pass to Pierre for a moment, because I'm struck by something that to follow on from what Nikita said. The European health data space, the data is largely coming from member states or other providers. So it comes into the health data space which you're creating and curating, but where is the quality control on that? Because the data that is fed in from the national level or from the hospital level, who's checking the quality of that? Because once it's in the health data space, you can't backwardly go back and check it, can you? How are you putting this quality and effectiveness monitoring in place when you're the recipient of data rather than the generator of data?
It's a very good question and a very important question. But, I'm going to give you a very bureaucratic answer. We are still in the process of developing our proposal. And for the moment, we are still in the phase where we are listening to stakeholders to come up with solutions. So I don't have a magic solution today. What I just simply can tell you that, if someone has a solution and has great ideas, don't hesitate to send those great ideas to us and to me, because it's clear that's one important issue, and that's something on which we need to make sure, of course, that the quality of data is correct. So it's also a difficult question, because how can we impose to an hospital in the middle, of a small area somewhere, a quality control which, is maybe too difficult and that could be counterproductive. So that we will need to find an appropriate balance. I don't have a solution for the moment, but of course as I say, we are open to listening to stakeholders to give us a solution. And if, Denise or Nikita has a bright solution, they are most welcome to submit it to us.
Thank you. So we have this challenge where we don't have an answer yet, which is when you have an information collection and transfer chain, there are weak points in it. and the strength of the whole system is only as strong as its weaker link. And it may be, as Pierre mentioned, at the point of data collection, which may be a small rural clinic. It may be in a more developed hospital, where its staff are very busy and somebody says to their assistant, please put this data in, and it doesn't happen. So this is something I think we need to reflect on as the plans for the health data space develop over the next few years, that we need to have transparent and robust quality and monitoring processes throughout the system. And I think this issue of quality comes up to another question that we've had, which took me a minute to try and understand what we're being asked. But we have this question about the social media listening. And I assume this is, for example, where, people are able to rate their doctors or rate their experience of a hospital. So what's the opinion on the ethics of AI analysis of social media listening? How do we make sure that, as a result, campaigns are not biased? So, for example, we know that people who are more unhappy are more likely to write a review. So if you're looking just at what people write about the service they received at a hospital, you're more likely to get complaints than praise. So this is of a human bias in the input. How do we ensure that doesn't become the basis of, say, policy decisions, because we've got this, weight that's more towards the negative than the positive? And I don't know, Nikita, if this is something you can help us with.
I think I have an answer that is more of a visual answer rather than a wordy answer. We have something like this for electrical appliance industry. We have food labels and food nutrition labels when we go purchase products in the supermarket. I'm not even talking about AI here. I'm talking about every IT system. We have no idea about how every IT system that we're using is processing our data, and what is the result of this processing, and if there is an AI inside, how is it making decision based on which data it was trained? Part of the solution, not the complete solution, is to build the transparent mechanisms of disclosure that will allow us, consumers of the data products, to be aware about how systems are doing data processing for us. Unfortunately, we don't have this in hands, and privacy policies and terms and conditions, they simply don't work. They're not a right instrument for this. We can't technically read 30 pages of Google privacy policy and terms and conditions when we are accepting it, and we're not the legal experts, everyone. So this is a part of a solution. A second is we don't have a full way to control. So we need to understand that it's a very blurred space in terms of our ability to control it. We can wish something to happen, but there always be a player.
Okay. Well, a complex answer to a complex issue. But I think it's been a really interesting exploration in this hour looking at the questions of equity, regulation and ethics. It's a delicate way forward, and I get the sense that we will all be finding our way forward in the coming years, because we've got the plans to build this health data space. There's an importance at European and national level to digitize in our health, but to do it in a way that creates the right balance and we keep humans in the loop. So thank you to our panelists, to Pierre, to Dennis and Nikita, and thank you for the participants. And I'd just like to close this session by saying at the beginning, we asked people what were the most important issues that came forward, and people said regulation and data security. And as our conversation evolved, the issue that came out top that really needs addressing is the issue of data security and privacy. So clearly people see where this is going, but this is an area where we want to discuss it more. Thank you all to the panel. We'll take a few-minute break, and then I'll be passing over to Anita to chair the next session looking at artificial intelligence and big data, and we've already launched a poll on that. So thank you to Pierre, Nikita, and to Dennis, and see you in a few minutes.
Thank you.
Thank you.
Thanks.
Bye-bye.
Bye.